Hi, we are going to review some of the classic key trials regarding lupus nephritis treatment from over the years. Today's talk will be at the rheumatology fellows level, although anyone is welcome to join. As a fellow in rheumatology, you will see and treat lupus patients almost on a daily basis. And you will encounter lupus nephritis pretty early on in your training, so having knowledge on these trials will definitely give you a head start. My hope is that after watching this video, you will not only be introduced to various treatment options for lupus nephritis, but that you will also gain an appreciation for how these treatment options developed and evolved over the years in the field of rheumatology. Today's talk will be broken down into 3 parts. 4 induction treatment trials in Section A, 3 maintenance treatment trials in Section B, and in Section C, I'll briefly go over the BLISS and AURORA trials, which studied the effects of a BAFF inhibitor and a calcineurin inhibitor, respectively. But before we start with that, let's clarify something: the term NIH dosing regimen/protocol. Let's say you're a brand new rheumatology fellow in a conference room while a case of lupus nephritis is being presented. All of a sudden, people are discussing about NIH dosing this or low dosing that, blah, 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 and you're wondering, what are they talking about? Well, they're actually referring to the medication named cyclophosphamide. Cyclophosphamide is one of the 2 backbone therapies used during the induction phase of lupus nephritis treatment. The other one being MMF, or mycophenolate mofetil, which goes by the brand name Cellcept. So IV cyclophosphamide was studied at the NIH during the 70s or the 80s. And the dose they used at the time was 0.5 gram to 1 gram per meter square, given monthly, then quarterly for at least 12 months. And the medication dosing for next cycle would be adjusted by the white blood cell nadir. And since the 1980s, this intermittent NIH dosing of IV pulse cyclophosphamide with glucocorticoid has been used in the treatment of lupus nephritis. But the problem with cyclophosphamide is that it's got a lot of side effects. Reproductive or bladder toxicities, including bladder cancer, are something we always worry about before giving cyclophosphamide to our patients. So using a lower dose of cyclophosphamide that can be used with reserved clinical benefit was looked into. And this is where our first trial comes into play. In 2002, lupus nephritis trial looked at using a lower dose of IV cyclophosphamide. So the dose was 500 milligrams every 2 weeks for 6 doses, and compared it to the NIH dosing. So for the NIH dosing, they used 6 monthly pulses with 2 quarterly pulses. This was a small trial with subject number of just 90, and both groups were followed by azathioprine or Imuran. Or another way to say that is that all patients were maintained on Imuran. Long story short, there was no difference between the drugs in terms of clinical benefit, but less side effects were seen with the 500 milligrams group. So this is where the eurodosing or low dosing of cyclophosphamide for lupus nephritis treatment came from. Next, let's take a look at the ALMS trial from the Journal of the American Society of Nephrology. This trial looked at whether a treatment option other than cyclophosphamide would be effective in treating lupus nephritis during the induction phase. And drug on trial, no pun intended, was Cellcept. So in the ALMS trial, which lasted for 24 weeks, 370 patients with classes 3 to 5 lupus nephritis got assigned to either Cellcept target dose of 3 grams per day or IV cyclophosphamide NIH dosing. And both groups received prednisone taper from a maximum starting dose of 60 milligrams per day. They looked at urine protein to creatinine ratio and stabilization or improvement in serum creatinine. What were the results? Bottom line, Cellcept and IV cyclophosphamide were comparable. But there is an additional clinical pearl that we need to remember from this trial, and that is that African American and Hispanic patients responded better to CellCept than to IV cyclophosphamide. This is an important point given that African American and Hispanic patients are more likely to have more severe forms of lupus nephritis and are more likely to progress to end-stage renal disease. So this was ALMS trial looking at the CellCept versus IV cyclophosphamide during an induction phase. The study actually had a second phase looking at maintenance therapy, and this was published in a different journal, NEJM, in 2011. Induction trial lasted for 6 months, but maintenance phase lasted a little longer because it went on for 3 years. But that makes sense, right? Because maintenance therapy will last longer than induction therapy in general. So the maintenance portion of ALMS trial compares CellCept to Imuran, and the dose for CellCept was 2 grams per day, and dose for Imuran was 2 milligrams per kilo per day. 227 patients were randomized in a 1-to-1 ratio, and up to 10 milligrams of prednisone per day or its equivalent was permitted. What was the result? This study showed that CellCept was superior to Imuran, looking at the primary efficacy endpoint, time to treatment failure, and with respect to time to renal failure and time to rescue therapy. The primary efficacy endpoint, by the way, was the time to treatment failure, defined as death, ESRD, doubling of creatinine, renal failure, or rescue therapy for lupus nephritis. Okay, next we have the Maintain trial from 2010. Just like the ALMS maintenance trial, this study also compared CellCept versus Imuran for long-term immunosuppression in lupus nephritis. In this trial, there were 105 patients who were pulsed with 3 daily IV Solumedrol 750 milligrams, followed by PO glucocorticoid and 6 fortnightly cyclophosphamide IV pulses of 500 milligrams. Then they were randomized to either CellCept 2 grams per day or Imuran 2 milligrams per kilo per day. They studied patients for 3 years and saw that 24-hour proteinuria, serum creatinine, serum albumin, serum C3 level improved similarly in both groups. The conclusion from this study was that fewer renal flares were observed in patients receiving CellCept, but the difference did not reach statistical significance. There was a long-term follow-up of the Maintain trial, published in 2016 in the same journal as the first Maintain trial. There was 13 lost patients to follow up from the original 105 patients. This time, they concluded the long-term follow-up data did not indicate that CellCept is superior to Imuran. So over a 10-year period, there was no difference in 2 drugs. By the way, this was a European trial, and the conclusion in the paper specified that the long-term data do not indicate that CellCept is not superior to Imuran as maintenance therapy in a Caucasian population suffering from lupus nephritis. So, CellCept or Imuran, which is really better as a maintenance therapy? From my personal experience, I have seen more patients being on CellCept or multi-target therapy than Imuran. But in some cases, Imuran may not be a bad option based on the above studies. Always remember you're treating an individual person and not a case. We should all strive to practice evidence-based medicine, but at the same time, we have to tailor therapy to an individual patient. Okay, so why don't we get back to the induction treatment trials? Next, we have LUNAR from 2012. This trial looked into whether rituximab could be used as an induction treatment method in patients with active lupus nephritis. 144 patients with class 3 or 4 lupus nephritis were randomized in a 1-to-1 ratio to receive either 1 gram of rituximab or placebo on days 1, 15, 168, and 182. They looked at primary endpoint of renal response status at week 52. Even though serology is improved, meaning double-stranded DNA complement levels, rituximab did not seem to improve clinical outcomes after 1 year of therapy. This is so disappointing because it seems like it's working because the serologies are improving. But again, we aim to treat the patients, not just the lab values. So this was a negative study. Leaving behind the disappointing LUNAR study, let's delve into multi-target treatment trials. Let's first talk about what the multi-target therapy is before discussing the actual trial. Multi-target therapy in the context of lupus nephritis is an addition of a calcineurin inhibitor to CellCept. Examples of calcineurin inhibitors would be tacrolimus, cyclosporin, or voclosporin, which will be discussed in a little bit when we discuss the AURORA trial. So how does adding a calcineurin inhibitor help with treating lupus nephritis? Well, calcineurin inhibitors help treat lupus nephritis by 2 completely different mechanisms of actions. One, they have immunologic effects via T-cell modulation, but in addition to that, they also have non-immunologic effects by stabilizing podocytes in the kidneys, which can lower proteinuria. Okay, back to the trial. So this was a 24-week randomized, open-label, multi-center study from China. 368 Chinese patients from 26 renal centers across China were divided into either multi-target therapy or IV cyclophosphamide group. The dosing for multi-target was tacrolimus 4 milligrams per day with CellCept 1 grams per day. And IV cyclophosphamide starting dose was 0.75 grams per meter square. But this was adjusted to 0.5 to 1 gram per meter square of body surface area every month for 6 months. Both groups received 3 days of pulse methylprednisolone followed by a prednisone taper. And at 24 weeks, primary endpoint of complete response was 45.9% in the multi-target group compared to 25.5% from the monthly IV cyclophosphamide group. Okay, so multi-target group did significantly better. But just a couple of comments here. One, the significant difference in response rate between the 2 groups may partly be potentiated due to the fact that proteinuria improves with calcineurin inhibitors via a non-immunologic mechanism of action like we talked about. It protects the podocytes. 2, also remember, this was a very homogeneous population that was represented in the trial. So whether we can see this kind of dramatic effect in the non-homogeneous US population is unknown. But nonetheless, since this trial, we see more multi-target being used in the US for the treatment of lupus nephritis. So this multi-target therapy for induction was taken out as a maintenance study. They took the patients who had responded during the induction phase, whether they got multi-target therapy or IV cyclophosphamide treatment, and patients who had received multi-target or continued on the multi-target therapy for maintenance, and patients who got IV cyclophosphamide induction were placed on Imuran. So what were the doses that they used? For tacrolimus, it was 2 to 3 milligrams per day. CellCept 0.5 to 0.75 grams per day, and prednisone 10 milligrams per day. For Imuran group, they received 2 milligrams per kilo per day of Imuran plus prednisone 10 milligrams daily. So both groups got the same amount of prednisone. 116 patients in the multi-target group and 90 patients in the Imuran group. So Imuran group had more side effects, whopping 44.4% versus 16.4%. A multi-target group had a lower withdrawal rate due to having this less side effects. In conclusion, multi-target as a maintenance for lupus nephritis resulted in a lower relapse rate and fewer side effects, suggesting that multi-target is an effective and safe maintenance treatment for lupus nephritis. If you read this article, you'll see in figure 3, it shows that the complete remission rate over 18 months between the two groups it's kind of interesting because initially multi-target group seems to have a higher remission rate, but over time, like over 18 months, Imuran does catch up. So in the long run, it seems like Imuran and multi-target maintenance were comparable. But before we could conclude that those two treatment options are comparable, just take a moment and think about whether, if you think of this from a patient perspective, or if you were to be the patient in this situation, wouldn't you rather get a better control of your disease in a couple of months versus over 18 months? Just something to think about. Okay, how are you guys doing? We're on the home stretch. Just stay with me for a couple of more minutes. I'll end today's talk with two trials, BLISS and AURORA. Okay, so first, BLISS. This is from 2020. This was a 2-year randomized controlled trial looking at Benlysta or belimumab, which is the inhibitor of BAFF or B-cell activating factor. BLISS was an international multi-center study with lots of patients. They had 448 active lupus nephritis patients from 21 countries who had biopsy-proven active lupus nephritis and assigned them into either 1 IV belimumab 10 milligrams per kilograms group or 2 placebo group, with both groups receiving standard therapy, which was either induction with CellCept or cyclophosphamide, and of course, both groups got glucocorticoids. People with CellCept induction received CellCept as their maintenance, and people who received cyclophosphamide got Imuran as maintenance. You're starting to see the pattern here, right? Anyway, so looking at the renal response at 104 weeks, belimumab group had a higher renal response at 43% compared to 32%. And by renal response, they looked at various things like urine protein to creatinine ratio less than 0.5, an EGFR no worse than 10% below pre-flare value or more than 90 cc's per minute per 1.73 meters square, and no use of rescue therapy. So in conclusion, this trial showed that adding belimumab to the standard therapy had a primary efficacy renal response than those who received standard therapy alone. So the important thing is, it's not just giving belimumab alone, it's an addition to the standard therapy. Finally, AURORA trial from Lancet 2021. This study looked at voclosporin versus placebo in the background of CellCept 1 gram BID. Voclosporin is a calcineurin inhibitor like cyclosporin, but it's more potent with less metabolic side effects. AURORA was also an international study involving 142 hospitals and clinics across 27 countries. They looked at people with class 3 to 5 lupus nephritis who were randomly assigned in a 1-to-1 ratio to either a PO voclosporin 23.7 milligrams BID or a placebo group with the background of CellCept 1 gram BID and steroids. Primary endpoint was complete renal response at 52 weeks, and voclosporin group achieved 41% 8% of complete renal response compared to 23% in the placebo group. Serious side effects in both groups were comparable at both 21%. So in conclusion, voclosporin added to the CellCept and low-dose steroid combination led to clinically and statistically superior complete renal response rate compared to the CellCept and low-dose steroids combo alone in the treatment of active lupus nephritis. Phew, okay, I know that was a lot. If you're new to rheumatology, watching this video for the first time may feel overwhelming, but that's totally understandable. We reviewed a lot of trials that normally would have needed several didactic sessions or journal club sessions. What you'd have learned in bits and pieces, I just put them all on one page. The reason for this is to give you an overview because having a framework like this, from which you could break down individual sections of topics, will help you tremendously to understand and retain information better. That being said, try going back and reviewing lupus nephritis section on your own. Whether it be reading a textbook, a review book, or reviewing these actual articles. Then come back and watch the video again. See for yourself just how much easier it is to follow the material the second or even a third time around. If you have any future rheumatology lectures that you would like to see, leave them in the comment section below. Thanks for visiting and good luck with your studies. See you next time.